Greetings! I'm so glad to see you again, and you will be very glad that you came to class today. In this video tutorial, I am going to arm you with very powerful information. Here we are at video number 443. It's the 31st video in our big unit on epithelial ovarian cancer. Last week, we started discussing the topic of prevention, and you learned that there is only one guaranteed, tried and true way of definitely reducing your risk of epithelial ovarian cancer, and that is removal of both fallopian tubes and both ovaries. In medical terminology, this procedure is called a bilateral salpingo-oophorectomy, or BSO. All these medical terms. This BSO is such an effective means of reducing your risk for epithelial ovarian cancer that there is an outright recommendation for all women with a known hereditary increased risk for epithelial ovarian cancer to have a BSO after completion of childbearing. But only 20% of epithelial ovarian cancers are hereditary. So I ended the last video with the question, what about the other 80% of women who do not have a known hereditary predisposition, but still want to reduce their risk of this horrible disease? And this video will address that. This video is entitled Elective versus Opportunistic versus Risk-Reducing Gynecologic Surgeries. In essence, it's all the surgeries that serve as prevention of epithelial ovarian cancer. And what I'll be presenting is all the factors you need to consider for deciding whether or not you would opt for a preventive surgical procedure to decrease your risk of epithelial ovarian cancer. In other words, is a preventive surgical procedure right for you? You know that there is no way I can present as much in my book as I can here on YouTube. So use them both. This is the first edition, this is the second edition. The second edition is much more current. Some topics, though, like this one, are only available here on YouTube. Since this video is for all women, no matter what your risk for epithelial ovarian cancer, let's begin by putting prevention of epithelial ovarian cancer into perspective. Now, when I say that I'm going to put it into perspective, I mean that I'm going to review what you've learned in previous videos, all of which set the stage for what we're discussing today. So, starting with incidence, you have learned that epithelial ovarian cancer is not a common disease. That is to say, your lifetime risk of getting it is not as high as your lifetime risk of getting any other disease pertinent to menopausal women. When you hold epithelial ovarian cancer up next to all the other diseases we've addressed in this menopause education, you get this. So your lifetime risk of ever having a heart attack is 1 in 3. Your lifetime risk of having osteoporosis is 1 in 4. Your lifetime risk of getting Alzheimer's is 1 in 6. Those are the 3 diseases that are due to estrogen deficiency at postmenopause. When it comes to cancers, your lifetime risk of ever getting endometrial uterine cancer is 1 in 29. For cervical cancer, it's only 1 in 45. For breast cancer, it's 1 in 7. And for epithelial ovarian cancer, it's only 1 in 78. This translates to an overall lifetime risk for epithelial ovarian cancer of 1.4% for women who are at average risk for it. So average risk is the risk for the vast majority of women who do not have a genetic mutation constituting a hereditary increased risk. These are the very women that are the focus of this video. So, from the perspective of your lifetime risk, you may think, why in the world would I subject myself to any kind of surgical procedure in order to decrease my risk for a disease with such a low lifetime risk in the first place? Well, maybe it depends on all the other factors you need to consider. If those other factors are significant, you may think a surgical procedure is right for you, even if your lifetime risk is 1 in a million. I mean, 1 in a million sounds like no big deal, unless you're the one. So let's consider all those other factors that you need to put on the scale in order to weigh your pros and cons for considering a preventive surgical procedure for epithelial ovarian cancer. Well, the next factor to consider is diagnosis of epithelial ovarian cancer. This includes everything from symptoms to screening tests to risk assessment tools. If it's an easy disease to diagnose and you can detect it early, then a preventive surgical procedure may be wrong for you. But if it's not an easy disease to diagnose and you can't detect it early, a preventive surgical procedure may be right for you. In video 434, you learned that the symptoms of epithelial ovarian cancer are of no use in detecting the disease early. All the symptoms fall into one of 3 categories. You snooze, you lose, meaning they are all quiet, vague, and non-specific. Wrong place at the wrong time, meaning they are all GI and GU symptoms rather than GYN symptoms. And too little, too late, meaning they all present at late stages of the disease. Here's the chart we made in video 434 depicting this. So, from the standpoint of difficult diagnosis, a preventive surgical procedure has more pros than cons for the average risk woman. The next factor is screening. Maybe the pros and cons of a preventive surgical procedure are a matter of screening in order to diagnose it early. If there is screening to detect it early, such surgery would be a con. But if there isn't, perhaps it's a pro. In video number 435, you discovered that there is no screening test worthy of detecting epithelial ovarian cancer early. They are all woefully inadequate. Here's the chart we made in that video. And to add insult to injury, video 436 faced you with the fact that even the risk assessment tools are of no help whatsoever either. All they do is take multiple unworthy screening tests and try to force 2 wrongs into making a right. Here's that chart. So we are left with a cancer that we diagnose at its very late stages. In essence, from the standpoint of both screening and risk assessment, a preventive surgical procedure offers more pros than cons. The only way to really diagnose epithelial ovarian cancer is to undergo a huge surgical procedure that serves the multiple purposes of confirming the diagnosis, grading and staging the disease, and dictating treatment. But wait, that's surgery too. The difference is in the timing. And because of the difference in timing, there is a huge difference in the actual surgical procedure you endure. With preventive surgery, the operation takes place before you suspect the possibility of epithelial ovarian cancer. With diagnostic or therapeutic surgery, The operation takes place after you suspect the possibility of epithelial ovarian cancer. And because the preventive surgical procedures of concern today are for purposes of prevention, you undergo a much more minor procedure of your own choosing in order to decrease your risk of ever getting the disease. In video number 437, you discovered that diagnostic surgery for epithelial ovarian cancer is much more extensive regardless of whether or not it turns out that you actually have the disease. So this means that from the standpoint of treatment, preventive surgery for epithelial ovarian cancer offers more pros than cons. If you do have epithelial ovarian cancer, the surgery is followed by chemotherapy. And although most women do respond well to the treatment with a disease-free period of time afterward, almost all of these cancers recur. And then you have to go through all that treatment all over again, only to ultimately die of the disease just months later. There's no question that failure to cure makes preventive surgery more pro than con. And all of this results in a very low 5-year survival rate for epithelial ovarian cancer. Here's the staging chart with the 5-year survival rates from video number 440. A full 80% of these cancers have survival rates of just 15 to 25%. That's horrible. If you compare these survival rates to all the other gynecologic cancers, you see why epithelial ovarian cancer is the absolute worst of all. If you go a step further and compare the number of deaths to the number of women with the cancer, you get the death to incidence ratio. And if you compare that for all of these cancers, you get this. All told, when you look at the big picture of epithelial ovarian cancer compared to any disease we've studied, it's the one over which you have the least control in terms of prevention. It's the one that is most difficult to diagnose, detected at the latest stage, most difficult to treat, and most deadly. And that's why women of average risk for it may choose a preventive surgery. There is no other guaranteed, tried and true means of definitely decreasing your risk for it. So let's talk about the different kinds of preventive surgeries and the different scenarios in which you might consider one. So the title of this video is Elective versus Opportunistic versus Risk-Reducing Gynecologic Surgeries. I chose that title because the surgeries that can decrease your risk for epithelial ovarian cancer can come about in different ways and for different reasons. My goal is to ensure that you have the opportunity to decide if one of them is right for you. So I'll start by defining and distinguishing our 3 categories of surgery. First is elective surgery. Elective surgery is any surgery that is not necessary. The problem with this definition is determining who gets to define the word necessary. You? Your doctor? Your insurance company? The guidelines? Some surgeries are obviously elective. Most people consider plastic surgery that is done purely for purposes of vanity to be elective. But beyond that, things become a bit arbitrary. If you had a C-section for a big baby with your first pregnancy, and then chose to have a second C-section for another baby of the same size, is that elective or necessary? A baby's size is not the only determinant of vaginal birth. The baby's position, the strength of contractions, the location of the placenta all play a part. It might be possible for you to deliver vaginally with your second pregnancy. If you have benign fibroids that are a nuisance but not life-threatening, is removal of the fibroids or removal of your uterus elective or necessary? What one person labels as elective, another might label as necessary. So the term elective is one that I do not like. Our second category is opportunistic surgery. Opportunistic surgery is elective surgical procedures done at the time of indicated surgical procedures. So this is when you actually need surgery for one reason, but you take advantage of the opportunity to add to the indicated surgery and have something else done at the same time. So part of the surgery is necessary, while another part is elective. For example, what if you have fibroids, which constitute an indication for a hysterectomy, but you choose to have both fallopian tubes and both ovaries removed also? The removal of your uterus is indicated because there is pathology in your uterus. But the removal of your fallopian tubes and ovaries is opportunistic because they bear no pathology. So if only a hysterectomy is indicated, but you choose to have your ovaries and fallopian tubes removed also, some would call the removal of your ovaries and fallopian tubes opportunistic. You took advantage of the opportunity to remove them. Our third category is risk-reducing surgery. Risk-reducing surgery is any surgery that is done specifically for purposes of decreasing your risk for a disease. So this is when you have no pathological reason whatsoever for surgery, and you choose to have it solely for purposes of reducing your risk for a disease. Again, the problem is determining who gets to define the word risk. How high does your risk have to be to qualify for labeling the surgery risk-reducing rather than elective? Remember that great big chart of risk factors for epithelial ovarian cancer? If you have only a family history of epithelial ovarian cancer rather than a known genetic mutation for it, does that qualify as risk? If you've had endometriosis and no pregnancies, does that qualify as risk? Should your insurance pay for your risk-reducing surgery? Should your doctor be able to refuse to perform your risk-reducing surgery? Where do you draw the lines between the words elective, opportunistic, and risk-reducing? I'm always telling you that everything is a matter of both benefits and risks, and this is no different. There are risks with all surgeries, and the general rule is that you only do surgery when the benefit outweighs the risk. But do you see how this can get a bit sticky? Trying to label each circumstance leads to different labels by different people. Separate from these three categories individually, is it possible for a surgery to qualify as more than one category? What would make it fall into more than one category? If you decide you don't want to take progesterone and choose to have a hysterectomy on purely an elective basis, but also have both fallopian tubes and ovaries removed at the same time, is it elective, opportunistic, or risk-reducing? Is your reason for the hysterectomy arbitrary enough to label it elective? If the hysterectomy is elective, can you still label the removal of your fallopian tubes and ovaries as opportunistic or risk-reducing? The problem with weighing benefit against risk for preventive surgeries is that the risks of the surgery and the risks of getting the cancer are imbalanced. There are inherent known risks of surgery such as bleeding, infection, damage to nearby anatomy, and the risks of anesthesia. But if your risk of getting epithelial ovarian cancer is less specific and less predictable, how do you determine this? I mean, the risk of it getting it is low, but the risk of dying from it if you do get it is high. So who gets to designate how much weight each risk holds? There is one situation in which the benefits of preventive surgery definitely outweigh the risks of it. And that is if you have a situation that already warrants surgery. If you already have pathology for which you need surgery anyway, you incur no additional risk by performing the opportunistic or risk-reducing surgery at the same time. Let's say you have fibroids in your uterus for which you need a hysterectomy, and you tell your surgeon, remove both fallopian tubes and both ovaries while you're in there. That opportunistic or risk-reducing measure changes absolutely nothing about your surgery, anesthesia, or recovery. Your surgeon is right there. All it amounts to is that I clamp here instead of here. People have elective and opportunistic surgeries all the time. Most plastic surgery is elective, but some people add things to it. So if you can dictate what you want in that realm, why not this one too? If you want risk-reducing bilateral salpingo-oophorectomy with your total hysterectomy, demand it. And if your surgeon says he or she cannot get to your ovaries because of the surgical approach, then change the approach. A surgical approach refers to the way your surgeon does the surgery. There are many different approaches. Through an abdominal incision, through your vagina, through a laparoscope, using a robot. It is not your job to choose the approach. Instead, just choose your goals. Let the surgeon choose the best approach for accomplishing your goals. This kind of situation is the most common one for which women really need to know what I'm teaching you in this video and in this unit. I cannot count the number of times a woman has consulted with me after having surgery, in which she kept her fallopian tubes and ovaries. And when she learns from me how much she could have reduced her risk of epithelial ovarian cancer by removing them, she's shocked. Every single time she asks, why didn't my surgeon tell me that? And I always answer with, I don't know. Actually, I think I do know. The surgeon didn't want to do anything more than was absolutely necessary. Now that could be because your insurance won't pay for it, or it could be because the surgeon was following guidelines. It could even be because of the most recent study claiming that epithelial ovarian cancer can originate in your fallopian tubes rather than in your ovaries. Most likely, it's because the surgeon just doesn't want to take the time to tell you the whole story and the whole truth like I do here in this education. But I believe you deserve to have all the information so that you can do what's right for you. The most common situation women encounter these days is one in which she suggests that the surgeon remove both of her fallopian tubes and both of her ovaries. This request can fall into any of our three categories: elective, opportunistic, or risk-reducing. And the surgeon responds with something along the lines of, well, the latest study shows that ovarian cancer can begin in the tube rather than in the ovary. So we can leave your ovaries and just remove your tubes. It makes me cringe. As I explained in video number 441, this has all come about in response to the infamous WHI study that terrified both women and doctors with regard to hormone replacement for menopause. And since then, anything and everything that can decrease use of hormone replacement has spun out of control. So here you have the most deadly of cancers, and you are planning a surgical procedure that offers you the opportunity to decrease your risk by 90%. And one study says that some of these cancers can begin in the fallopian tube rather than in the ovary. And that justifies talking a woman who wants risk-reducing surgery out of removing her ovaries? If risk reduction is the goal, who cares where epithelial ovarian cancer begins? It can begin on the moon for all I care. It is wrong to deny any woman the right to decrease her risk for it if she so chooses. What if you remove your fallopian tubes, but there is already an occult epithelial ovarian cancer in your ovaries? Well, if your surgeon performs a bilateral salpingectomy, or BS, instead of a bilateral salpingo-oophorectomy, BSO, you will probably die from the cancer. Another thing that bothers me greatly about promoting BS instead of BSO is that it's another example of putting the emphasis on the wrong syllable. If you go back to the reproductive risk factors for epithelial ovarian cancer, they are all due to an increased number of menstrual cycles. Here's the chart we created in video number 427 on that. All of these factors are governed by your ovaries. Your fallopian tubes have nothing at all to do with any of them. So how did anyone start focusing on your fallopian tubes? How did anyone decide that BS is the best solution? And let's not forget that the disease women fear most is breast cancer. They shouldn't, but they do. And the only risk-reducing gynecologic surgical procedure that has any impact whatsoever on decreasing your risk of breast cancer is bilateral oophorectomy. The risks for breast cancer and epithelial ovarian cancer are almost identical. Here's the chart demonstrating that from video number 421. The risk factors for breast cancer are on the left. The risk factors for epithelial ovarian cancer are on the right. Just look at that overlap as emphasized by the colors. So if you remove both of your ovaries, you reduce your risk for both epithelial ovarian cancer and breast cancer. But if you remove only your fallopian tubes, you don't. It is your right to decide what you want removed from your body at the time of surgery. In consultations, I help women decide what they want. I don't decide for them. I don't even give them my opinion or my recommendation. I merely ask them a series of questions so that they can arrive at their own decision. Once they decide what they want, I tell them, your doctor is your employee. You tell your surgeon precisely what you want him or her to remove. Do not leave it to chance. It is your right to do what's right for you. There is no right or wrong indication. We do not all want the same things. So you get to write your own story here. If you want your fallopian tubes and ovaries removed, demand that your surgeon remove them. In the video before this one, I presented every surgical procedure along with each one's risk-reducing potential. In essence, what it boils down to is the more organs you remove, the more you reduce your risks for various cancers. And of course, we're talking only about reproductive organs that you don't need anymore. Here's the chart we created in video number 442, listing the cancer risk reduction you achieve with removal of each individual reproductive organ. And here's the chart of risk reduction with all of them together from that same video. This one is organized by surgical procedure, comparing what each one accomplishes in terms of risk reduction for cancers. So just be aware of the degree of risk reduction you can achieve by opting for one surgical procedure versus another. You have the right to do what's right for you. There are many problems with the study claiming that some epithelial ovarian cancers originate in your fallopian tube, and therefore women at average risk of epithelial ovarian cancer should have opportunistic risk-reducing removal of only their fallopian tubes, rather than both their ovaries and fallopian tubes. The first problem is that only some, if any, epithelial ovarian cancers originate in your fallopian tubes rather than in your ovaries. So how do you know in advance whether to remove just your fallopian tubes rather than both your fallopian tubes and ovaries? The second problem is that while these women may only have the average degree of risk, they constitute 80% of the epithelial ovarian cancers. If only some of these 80% have epithelial ovarian cancers that originate in their ovaries, they still account for the vast majority of cases. The third problem is that this study only considered one of the 4 different types of epithelial ovarian cancer. It only assessed serous epithelial ovarian cancer. And of the serous epithelial ovarian cancers, it only assessed the highest grade of serous epithelial ovarian cancers. It is true that these high-grade serous epithelial ovarian cancers account for 95% of all serous epithelial ovarian cancers. But it's important for you to know that it did not consider any of the other kinds of epithelial ovarian cancers for which you reduce your risk by having one or another surgical procedure. The fourth problem is that a subsequent study compared removal of just the fallopian tubes to removal of the uterus or mere bilateral tubal ligation. It did not compare removal of both fallopian tubes to removal of both ovaries and fallopian tubes. This is why I always tell you to pay attention to the frame of reference. Frame of reference is the compared to what question. In last week's video, I delineated all the cancer reductions for each organ you remove. So this study compared your risk reduction between part of the aqua row, or the bottom yellow row, versus the orange row. So let's isolate those and put them up next to one another and see how they compare. On the left side of the chart, you see the 2 procedures the study used for purposes of comparison to bilateral salpingectomy. They are hysterectomy, which is removal of your uterus, and bilateral tubal ligation. On the right side of the chart, you see bilateral salpingectomy, which is removal of both fallopian tubes. You can see that neither of the 2 procedures on the left side contributes at all to the one kind of epithelial ovarian cancer of concern, serous epithelial ovarian cancer. So the comparison is completely irrelevant. They've compared apples and oranges. And since the whole issue revolves around whether epithelial ovarian cancer originates in your ovaries or your fallopian tubes, the only logical comparison would have been between removing both your ovaries and your fallopian tubes, or just your fallopian tubes. And frankly, they should have also compared removal of just your ovaries to removal of just your fallopian tubes. Had they done that, they would have gotten this. Now you see that we're comparing apples to apples. Your ovaries and fallopian tubes are what matter. Why in the world they compared any other anatomical structures is beyond me. This is why I tell you never to rely on a single study. Studies do goofy things like this all the time, and if you read them with a critical eye like I do, you see all sorts of flaws. The fifth problem with this and other studies is the short duration of follow-up. Because it costs money to conduct studies, the length of time devoted to follow-up is not always adequate. This is most pertinent to cancers, which develop over a very long period of time. You can't study in a short period of time something that develops over a long period of time. And the problem with the study that mismatched the comparison of bilateral salpingectomy with hysterectomy or bilateral tubal ligation is that the follow-up was too short to be meaningful. If a woman has her fallopian tubes removed at age 40, but the mean age of women with epithelial ovarian cancer is 63, follow-up would have to be at least 25 years, but it was only 5 years. 5 years is a typical duration of follow-up. The sixth problem is the age at which women typically have these procedures. Age matters, so anything that influences age will confound the data. For instance, if you compare removal of just the fallopian tubes to removal of both ovaries and fallopian tubes, you inevitably discover that younger women commonly undergo removal of only their fallopian tubes, while older women more commonly undergo removal of both their ovaries and fallopian tubes. Well, that alone will skew the data. The older women are more likely to get epithelial ovarian cancer regardless of any risk-reducing surgery. This is based on their age alone. So the study that set this whole push to leave your ovaries and remove only your fallopian tubes is just about the looniest thing I've seen in a long time. You know, it's so common for people to want things both ways. If you look at the history of removing ovaries at the time of surgery for benign diseases, as I described in the last video, and you compare it to how gynecologic surgeons practice today, you see that it's an example of wanting things both ways. It's also an example of the pendulum swinging from one extreme to the other. Historically, we removed ovaries electively or opportunistically in any woman who didn't need them for reproduction or estrogen, because the risk of epithelial ovarian cancer outweighed the benefits of keeping them. It was so easy to replace estrogen that it didn't make sense to leave a woman at risk for epithelial ovarian cancer. But now it's the opposite. Because of fear induced by the WHI, they want it the other way. Now it's leave the ovaries and put women at risk of epithelial ovarian cancer so that hormone replacement isn't necessary. The whole attitude about estrogen itself has been distorted by fear also. Now, the dogma is that we can't replicate Mother Nature's masterful creation of estrogen and all its beneficial effects, so don't remove your ovaries. But when your magical ovaries die and you lose your estrogen spontaneously, don't replace the wonderful hormone that was so beneficial. It's such a contradiction. If your ovaries put you at risk for the deadliest of cancers, then remove them if risk reduction is warranted. But don't hesitate to replace that wonderful magical estrogen that prevents other deadly diseases. If you are considering any kind of surgery for any reason whatsoever, you should have a consultation with me first before you schedule the actual surgery. I will take the time to school you in all your options so that you don't fall prey to a procedure that accomplishes less than you desire. I will do what your surgeon does not take time to do. I will lay out all the pros and cons of all your options. The choices are all yours, but at least you'll have the opportunity to consider all your options along with their pros and cons. To summarize, elective, opportunistic, and risk-reducing surgery are means of decreasing your risk of epithelial ovarian cancer. There is some risk reduction for every reproductive organ removed. The more organs you remove, the more you reduce your risks for various cancers. But the only surgical procedure that has any impact on reducing your risks for both epithelial ovarian and breast cancer is bilateral salpingo oophorectomy. I showed you a lot of charts today, but not a single one of them was new. If you've been watching my videos in order, you should have recognized all of them. And you see that I presented them before this video for a reason. So while the charts do contribute to the summary, they mostly help you put the reasons for considering risk reduction surgery into perspective. I'm not going to repost them specifically for this video. You'll need to watch the original videos in which I created them in the first place. It's one of my ways of urging you to watch these videos in order. So that's it for today. If you're considering any kind of surgery for any reason whatsoever, please, please, please have a consultation with me before scheduling your surgery. I will help you define your goals. And once you define your goals, knowing which surgical procedure is right for you will be a breeze. Do not have the surgery first and then regret that you didn't know about the options and benefits of risk-reducing procedures. Go to menopausetailor.me to schedule your consultation. I do them all via video conferencing. Subscriptions to my newsletter and channel are really easy. All you have to do is click here and now. And if you want to see all sorts of stuff about my life outside of these videos, go to Facebook, Instagram, Twitter, and TikTok. Next week, I'll present your reproductive and hormonal options for preventing epithelial ovarian cancer. And that video will probably knock your socks off. Bye.